series is presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal Child Health Bureau of the Health Resources and Services Administration. My name is Diane Baker. I'm a professor of nursing at California State University, Sacramento, and on clinical faculty in pediatrics at the University of California, Davis. Through a recent partnership with the National Center for Medical Home Implementation, I've been able to translate and tailor concepts of care coordination for practicing school nurses. I gratefully serve as your moderator for today's webinar. Before today's speakers begin, I would like to share with you just a few things about the webinar functionality. The slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the right-hand side of your screen. These questions will be answered at the end of the presentation. If the webinar faculty do not have time to answer your questions during the webinar, the National Center staff will send you an answer directly via email at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website. After the webinar, you will receive an email with a link to the webinar evaluation. Please take some time to complete this evaluation so we can continue to improve the content and manner of presentation in the future. This webinar is the third and final offering in the 2015 webinar series, Pediatric Care Coordination, Beyond Policy, Practice, and Implementation. When the series was developed, there was every effort made to present care coordination in a very practical way, moving beyond simply the idea that care coordination was the right thing to do. The National Center wanted to show examples of real practices providing real care coordination, programs that through fostering partnership have made care coordination work in their communities, and the importance of recognizing value and measuring positive impact. If you missed the previous webinars, information on how to access the presentations, as well as the answers to the participant questions, will be provided at the end of each of the session today. It's important to note that work in the field of pediatric care coordination, including this webinar series, is often guided and enhanced by the 2014 American Academy of Pediatrics Policy Statement on Care Coordination. This document gives practical guidance and provides multiple resources. You'll note that the patient and the family are front and center in this policy. The team is what makes care coordination successful and sustainable. We all know that families are the key members of the team. This is why the family partnership perspective is also a key component of this entire webinar series. This slide is a favorite of many medical home professionals and families because it shows complexity. It shows reality. Simply or not so simply, it shows the ordered chaos that embodies care coordination for many families. At the center, amidst this chaos, is the child and his or her family, and that is what we all need to keep in mind. The National Center thanks Mrs. Kristen Lynn for this graphic, and you'll note her web address on the side. I have visited this site, and there's many helpful resources there. Just a reminder about the objectives for today's webinar. Take a moment to look at them briefly. I am honored to introduce to you the first of today's speaker. Richard Antonelli is the Medical Director of Integrated Care at Boston Children's Hospital and is on faculty at Harvard Medical School. Dr. Antonelli has published outcome and cost data of care coordination services for children and youth with special health care needs and their families. He has consulted on care coordination and integration methodologies and measures to multiple states and to U.S. federal agencies. He is currently funded by the Lucille Packard Foundation for Children's Health to develop a family-reported measure of care coordination. Dr. Antonelli directs the National Center for Care Coordination Technical Assistance with funding from the U.S. Maternal and Child Health Bureau in partnership with the National Center for Medical Home Implementation at the American Academy of Pediatrics. And with that, welcome Dr. Antonelli.
Thank you, Diane, very much. It's really a privilege to be able to bring this content to this audience, and in particular, I want to acknowledge the work of all of the various team members, both here in Boston and across the country. I hope many of you will see the input that you've had into the work that we're sharing. So I have no relevant financial relationships with manufacturers or commercial products. I do not intend to discuss any unapproved investigative use of a commercial product device in my presentation. Next slide, please. The National Center for Care Coordination Technical Assistance. The mission is to support the promotion, implementation, and evaluation of care coordination activities and measures in child health across the United States. Hannah Rosenberg, who is one of our presenters today, is the manager of that center. I have the privilege of being the director of that center, and it is a close collaborative partnership between the National Center for Medical Implementation at the American Academy of Pediatrics and funded by a cooperative agreement through the Maternal and Child Health Bureau of HRSA. This is a place where you can come for technical assistance, information, access to tools. Next slide, please. This will give you a sense of this evolving community of pediatric care coordinators. The map of the United States, you'll see our colors of yellow and green. The activities are updated through May 1st of 2015. Over 20 different institutions across these states are involved with utilizing a pediatric care coordination curriculum, which was funded by the U.S. Maternal and Child Health Bureau and co-created in partnership with our Family Voices partners, with nursing, social work, and physicians, as well as community providers such as early intervention programs and educators. So you'll see in yellow states that are involved in the early stages of engagement with the work, expressing an interest in developing workforce capacity, care coordination activities, whether at an institutional level or statewide programs. And similarly with green, entities that have used the curriculum to begin to build out their workforce as well. Next slide, please. So benefits of developing a community. I think I became mindful of this when it seemed at least once a month, Hannah and I were getting phone calls or emails from around the country asking about this. And it was with great humility and excitement that we partnered with the AAP, National Center for Medical Implementation, to promote this work that the Maternal and Child Health Bureau has been supportive of and is giving us the inspiration to move this forward. So this developing community, sharing resources, what works, what doesn't work, not reinventing the wheel, learning from others about the challenges and how you overcame these barriers, and looking for collaboration. I'd say at this point, so not only are patients and families and caregivers at the center, but care coordination is a team sport, meaning that it's not owned by any one particular entity. You'll see a little bit more of the flavor of that as we go farther into this talk. But we really are all in this together, and this notion of building a community of care coordination that has access to tools and measures with support from various policy entities is our goal. Next slide, please. So, framework for a high-value care delivery model. We know that the medical home is that high-performing primary care delivery entity. Standalone, it can't deliver optimal outcomes. But as a component of an integrated system, it is absolutely essential. But it needs appropriate financing to be able to do this work, specifically around care coordination and integration. It needs access to a trained workforce. It needs access to resources which support integrated care work. And one of the presenters today, my colleague and collaborator, Dr. David Urian, is a child neurologist who will tell you about our work today, but really starts to support the delivery within these so-called shared care or collaborative care models, where primary care and specialty providers are delivering care in new ways to achieve optimal outcomes. And technology. Technology is necessary but not sufficient to advance care integration and coordination. So we do know that integration is essential for success. Next slide, please. But care coordination by itself is not sufficient to achieve an integration across that entire spectrum. And I'm talking outside of, or in addition to the medical component, there's the educational component, the family support component. Think about that care map that we showed of Kristen Lind and her son Gabe. So we're talking about care coordination across these various systems. Dr. Renee Turchi and I had the privilege of representing the Committee on Children with Disabilities, and in my case, the Medical Home Project Advisory Committee, in being the co-lead authors on the AAP's policy statement of care coordination. And in that policy statement, we were encouraged to think very broadly about care coordination. And I operationally think about care coordination is that set of activities in the space between visits, between hospital stays, between various agencies and organizations. And the only way to succeed is to engage all of these stakeholders, including the patients and families, as participants and partners. That theme of team approach, interprofessional training and performance, inclusion of families as full partners will be recurring throughout our presentation today. Next slide, please. So thinking about accountability, we're in the era of healthcare reform. The term accountability is embedded in a lot of regulatory language. We've been able to gain enough experience to know that you have to have various degrees of accountability across the system of care. So it's not just in the primary care setting, it's not just in the medical setting. This is where partnership between medical and public health organizations, between the medical home and the school environment, all come into play. Transparency of performance, meaning measure it and promote it. And we need to identify incentives to support these activities in the space between. You do need an educated workforce. You need to have support for these activities, and you have to have support for measurement as well. Next slide, please. This is a blueprint of sorts for the integrated care program that we have at Boston Children's Hospital. On the left side of that slide, you can see the primary care, community-based primary care, as well as health center-based and private practices, and the elements of that so-called patient and family-centered medical home: care coordination, accessibility, cultural effectiveness, comprehensive care. Thinking about connecting with the hospital as that tertiary entity. Development of approaches to population health, serving to support and integrate across those providers. And in the middle are some of the elements of care integration. Interprofessional education, right at the top, including families as faculty and learners, bringing together nursing and social work and physicians and trainees and our educational folks there. Communications, the use of technology-based solutions like portals, for example. Thinking about defining handoffs of care. What's the referral question? What would our relationship be between a PCP, a family, and a subspecialist going forward? And measuring in that space. Optimal models of care, and you'll be hearing a little bit about that from Dr. Urian when he gets to his portion of the presentation today. Care management across the spectrum, and actually measuring according to the domains of the so-called triple aim, both the quality and the experience and the cost of care. Next slide, please. So these are some of the tools and processes that we're using here at Boston Children's Hospital and that are available through the National Center for Care Coordination Technical Assistance. We have the Maternal and Child Health Bureau funded care coordination curriculum. We've got a care coordination measurement tool that Hannah Rosenberg will be speaking with us about today. We are nearly finished with the validation of the Pediatric Integrated Care Survey. It is a family experience survey of care integration for children and youth with complex needs across systems of care. There's a companion measure that I want to call out here from my colleague, Dr. Rita Mangione-Smith from Seattle Children's, for the family experience of care coordination. The Family Experience Care Coordination and the Pediatric Integrated Care Survey appear to have a lot of opportunities for synergy in the measurement space. We also have developed a tool to assess families' readiness for discharge, working with my colleague, Dr. Jay Berry, to try to reduce the risk of unplanned readmissions for pediatric patients. And then finally, framing an approach to care planning. It's more than just having a care plan. There has to be an embedded, measurable process around care planning that helps to identify the strengths and needs of patients and families, not just their care needs, but their care coordination needs as well. Next slide, please. I do want to call out this idea that fee-for-service by itself will not successfully encourage the evolution of measurable care coordination activities. Fee-for-service as a base with an additional allowance that can and should be risk adjusted is one approach that many states are using now. And global budgets, as we start to inform the development of global budgets where entities are taking financial risk, it's critically important to know the true costs of care. Those costs go beyond what your typical charges are for face-to-face care and need to document these care coordination activities and outcomes. The Affordable Care Act is providing some opportunities in this space. Next slide, please. So working with strategic partners here at Boston Children's Hospital, buy-in from physician and nursing and social work leadership, family partners. The Massachusetts Family Voices entity is housed administratively at the Massachusetts Federation for Children with Special Needs. Family partners are involved prospectively in all of our projects on the integration side. We're developing evolving relationships with the business community, including groups like the National Business Group on Health, where we can start to measure value of outcomes so that the employers, the purchasers of care, if you will, are actually interested in and advocating for our care models. And the payers themselves, working with commercial payers that recognize that they have to have some way of getting optimal outcomes, identifying, measuring, and capturing the outcomes of care coordination is essential. So it's a really interesting dynamic to have payers interested in our work. And as I mentioned, our outcomes tied to the triple aim: better health, better care, reduced costs. Next slide, please. So we talked a little bit about some of these high-quality handoffs of care. We've defined a handoff as a transfer of pertinent knowledge between members of a patient's care team, often conducted in anticipation of an upcoming patient encounter. We've started to measure, in our work here in Boston, how often a patient is in a clinic with a subspecialist, that the subspecialist knows why the child is there. And similarly, to ask the subspecialist to get what you needed from the subspecialist. So our approach is to enable the care team across the continuum to maximize the value of every patient interaction by ensuring that relevant knowledge by one part of a patient's care team is available at the right place and time for other members of the care team. Next, please. These are some of the elements of that high-quality handoff. The goal of the anticipated encounter, including the perspective of the family, patient, and the primary care provider. Relevant clinical information, what's been done to date, including labs and imaging studies. A model of the referring relationship. Is this a one-time consult? Will it be ongoing co-management? Time sensitivity of requests and action items that then get embedded into a care plan. Next slide. These are some of the domains of care coordination created by a CHIPRA grant by Massachusetts Medicaid, Child Health Quality Coalition here in Massachusetts. 5 key elements of care coordination: a needs assessment, continuing engagement, care planning and coordination, facilitating those care transitions, connecting with the community broadly, with community resources, including schools, and transitioning from pediatric to adult care. We have some sample measures there. I won't take the time to read them, but I'll highlight a couple that we're using. So use of a structured care coordination needs and strengths assessment tool. Asking the family about their experience in being involved in co-creation and implementation of a care plan, and looking at the percentage of time where referrals were made or labs were requested, that in fact the results were secured and shared back with the family and the referring provider, what we call close the loop. Next slide, please. And I'll hand it off to Hannah.
Yes, thank you, Dr. Antonelli. Lots of helpful information there for all of us. Now it's my honor to introduce Hannah Rosenberg. Hannah Rosenberg is a program coordinator at Boston Children's Hospital and the manager for the National Center for Care Coordination and Technical Assistance. She focuses on research and quality improvement work specific to pediatric integrated care and care coordination for children and youth with special needs. Along with Dr. Antonelli, Ms. Rosenberg is involved in the development of a measurement tool that assesses family-reported perceptions of pediatric integrated care, identifying workforce capacity to use the MCHB-funded Pediatric Care Coordination Curriculum, and the development and utilization of care coordination measurement tool to capture the value of care coordination. And now I'll turn you over to Ms. Rosenberg. Thank you.
Thanks so much, Diane. I have no relevant financial relationships with manufacturers of any commercial products or to disclose. So for the next few minutes, I'm going to introduce one of the key tools that Dr. Antonelli had mentioned in his portion of the presentation. I'm going to talk a little about how we both utilize the tool here at Boston Children's Hospital and also how we provide support and technical assistance to our collaborators nationally that are working to adapt, implement, and then evaluate use of the tool. And after I speak, I will be turning it over to 2 of our partners here at Boston Children's Hospital who act in clinical leadership positions and have implemented use of the tool and have some experiences to share. So the Care Coordination Measurement Tool is a value capture tool that is meant to track care coordination activities that are currently provided but are not accounted for, tracked, or reimbursed in any way. And before I start speaking specifically to the tool, I'll mention that what I'm going to show you is what we call the medical home core version of the care coordination measurement tool that was designed for primary care. But the tool is intended to be adapted to reflect activities and outcomes of teams in very diverse settings. We are working with sites both here at Boston Children's Hospital in the greater Boston community, and then with our national partners to adapt the tool to reflect activities of different settings. So we encourage that process. And the tool can also be implemented in different ways depending on the overall objective of utilizing the tool. So we have groups that are utilizing it for every care coordination encounter within a specific team, within a clinic or department, that use the tool once a week or designate a specific time every quarter to collect care coordination data. The tool can and has been used in paper version and in a web-based version, which I'll speak to a little later. And it's currently cited in the ARC Atlas and can also be found and downloaded at the Boston Children's Hospital website, and that link is included in the slide. Next slide, please. So CCMT, Care Coordination Measurement Tool, is a value capture tool, again, designed to track care coordination activities that are currently being done but not being accounted for or reimbursed. So we identify it as tracking the true cost of care and the true value that effective care coordination service delivery brings. It was initially designed to be used in a pediatric primary care practice as a quality improvement initiative. And we currently now say that the two main purposes of using CCMT are for quality improvement and to inform financing mechanisms. And I'll speak to each of those buckets as well. Next slide, please. So today, CCMT is available in the public domain. We encourage all users to think through the adaptation process, which I will be speaking to. And many institutions are using it in pediatric and adult care settings, in primary and specialty care, in research settings. And we also have many family partner institutions that are currently using it to capture the value and quantitatively demonstrate the value add that they are providing to families. Whereas before use of the tool, they were only able to report qualitatively the value add. And next slide, please. So what I'm showing here is the medical home care coordination measurement tool designed for primary care. And I'll quickly speak to this slide. So the categories that we currently have that we encourage users to track are patient level, focus of encounter, care coordination needs of a patient and family, time spent to achieve the care coordination need, staff member completing the care coordination activity, a clinical competence, and this is, we include this in both the quality improvement and finance bucket to track if clinical personnel are completing activities that are not, that don't require clinical competence. We call that an opportunity for accountability shift. Activity to fulfill need, and then outcomes in the far right column. And these are both prevented and occurred outcomes. And we really say that this is the main value capture element. Again, all of these categories should be thought through and adapted and modified when used in different settings. Next slide, please. So in our work both at Boston Children's Hospital and with our external collaborators, we have designed a general process and set of questions for any new user to think through when utilizing the tool. I won't go through all of these individual questions. These slides will be available to you after the webinar. But generally we ask and we encourage new users to think through what their ultimate goal of collecting care coordination data is. Is it for quality improvement, to inform a new financial model or financing mechanisms, or both? Who will be completing CCMT? Is it one individual, or is it many individuals who are acting in the same team or in the same clinic or department? And then to think through qualitatively before designing and implementing the new tool, what elements would a new user include from the medical home core tool, and then what elements and new activities would need to be added to accurately reflect and capture what was happening in a particular clinic or department or institution. And then the last question we encourage users to ask is would tool validation add to the data capture? And generally we say when informing financing mechanisms, validation is very valuable. And we have also defined a process, which I'll quickly speak to. And we, in any new users, through our National Center for Care Coordination Technical Assistance, we can provide more support in that realm. Next slide, please. So to inform the implementation process, again, we would ask users and encourage them to think through how will CCMT be implemented through web or paper-based, and then how often will it be completed. And these are questions, again, that we have developed a process for and can provide further technical assistance through our center. Next slide, please. So the two main buckets that we say the CCMT should be used for, again, are quality improvement and financing. And these general categories are what we have defined for each clinic to think through their overall objective and decide kind of what their main goal in implementing CCMT is. Again, validation would be most necessary when addressing the finance domain. And in the past, generally, the process has been developing episodes of care case studies, and including a subject matter expert in designing and then evaluating these episodes of care, and achieving inter-rater reliability by having multiple users complete CCMT in the context of these episodes of care. And on in our team, we have a survey methodologist who we work with, who has worked with additional clinics both at Boston Children's Hospital and externally to help define this process for them as well. Next slide, please. I'll quickly speak to this. So this was a 2008 a study that was published on a national study using the care coordination measurement tool. And next slide, please. Some of the main encounters that were prevented that were published in this study were a visit to a pediatric office, emergency room utilization that was unnecessary, and a subspecialty visit that was unnecessary. And so in the context of this study, the authors were able to publish and quantitatively demonstrate the cost savings due to effective care coordination service delivery, and clearly define what care coordination activities and what resources were needed to achieve these cost savings. Next slide, please. One of the key findings in this early study was that non-revenue generating office nurses drove the most system-level cost savings in terms of avoiding unnecessary ED utilization and office visits. Next slide, please. So again, generally, what some overall suggestions that we have when there are new users adapting and thinking through the implementation process of CCMT is to early on develop a group that will work on the adaptation of the tool and involve the people who will be ultimately collecting this data. Ensure that everyone completing the tool is working with the same set of definitions. So early on, define and distribute, and ensure that everyone is aware of the definitions being used in the tool. And then generally, we suggest that a usability and feasibility trial is done before the tool is actually formally implemented in a setting. Next slide, please. These are generally the steps that we say are necessary to successfully implement CCMT, make the strategic and tactical decisions, define an episode of care model, and validate the tool if necessary. modify, implement, and then potentially incorporate CCMT into an electronic format so it can be most easily implemented into current workflow. Next slide, please. I'll be turning over to Dr. David Urian and Tammy Chase, who will speak about their experiences using CCMT with their team. So quickly, I will give a little bit of background. So at Boston Children's Hospital in the Integrated Care Program, we work with multiple different clinics, both primary care and specialty clinics, to use CCMT. We have been able to work and develop an electronic version using REDCap that we have incorporated and is currently available by link in our EMR. We have spent some time doing usability and feasibility testing and have currently implemented both in Department of Neurology clinics, in Martha Elliott Health Center, a community pediatric practice, in their behavioral health population, and then again have worked with multiple other clinics to help them guide them through this process. Next slide, please. And I'll turn back to Diane to introduce Dr. David Urian. Thank you.
Yes, thank you, Ms. Rosenberg. Now it's my pleasure to introduce our third speaker for today. David Urian is the Director of Education and Residency Training Programs in Clinical Neurology and Clinical Neurodevelopmental Disabilities, and the Director of Behavioral Neurology Clinics and Programs at Boston Children's Hospital. Dr. Urian has a large outpatient practice focusing on behavioral neurology and is an Associate Professor of Neurology at Harvard Medical School. Dr. Urian will discuss how the care coordination measurement tool is being utilized in the Integrated Care Program in the BCH Department of Neurology and will demonstrate the importance of engaging subspecialists in care coordination. Dr. Urian.
Thank you very much. Next slide. So I have no relevant financial relationships with manufacturers of any commercial products or provider of commercial services discussed in this activity, and I do not intend to discuss any unproved or investigative use of commercial products or devices in this presentation. Next slide, please. So what we're going to talk about today is how it is we've utilized some of these tools in the context of subspecialty clinics, particularly in the Department of Neurology. And one of the settings that we'll be returning to is one that you see here, our Rett syndrome clinic. Rett syndrome is a neurodegenerative disorder that is transmitted genetically. And as you can see by this slide, if we use the number of places that a family and their daughter with Rett syndrome go as a metric or a proxy for complexity, this patient population certainly defines complexity. You can see that a huge number of visits over the course of a given year transpire for persons and families dealing with Rett syndrome. We then decided to embark on looking at care integration within this setting. The clinic is large enough, it serves about 200 families, so that results that we found would be scalable and useful, and yet it's small enough that we thought in an early trial we could get our arms around this problem. So next slide, please. And so the first phase was to test the feasibility and usability of this clinical care metric, or care coordination metric, within the context of the clinic. And we saw several things over a trial period. First of all, that it was valuable. 42% of the instances of care integration, care coordination that were done by our clinic nurses, who are, as has been mentioned before, technically non-revenue generating in a fee-for-service world, yet we can see that 42% of those prevented a provider from needing to call families, therefore freeing up nurse practitioner or physician time for other tasks, such as patient care or direct patient care. 15% of these also avoided an extra visit to a subspecialist, that is a non-scheduled between the spaces visits to a specialist. And so again, as we move into a world that is more accountable, we think that this has captured something very important. In addition to that, when we look at this notion of is everybody working at the top of their license, you can see from this slide that each role conducted really only a handful of activities outside their primary skill set. So that in our clinic's instance, care coordination was being done both by RNs as well as resource specialists who are people that have come to us usually with a background either from early intervention or special education settings, mostly with master's level training, but not in clinical settings per se. And as a result, we can see that most of these folks are actually working most of the time at the top of their license. It is a time-intensive activity. 64% of the care coordination activities took over 10 minutes to complete, and 9%, so that's almost 1 out of 10, took more than 30 minutes to complete. So this is a large amount of time that's being freed up. So if we look back at that number of 42% of these prevented a provider from needing to make the phone call, we can see that this adds up to a fairly substantial amount of time, which is then available for other activities within the department. Next slide, please. So the first question that we had in looking at encounters themselves was the nature, the warmth, if you will, of the handoff from primary care providers referring into the Department of Neurology here. And if we looked for the presence of a referral request, particularly that dealt with what was the question the primary care provider was actually asking us, what was the anticipation of what care would look like moving ahead? Was this a transfer of the totality of this aspect of the patient and family's care to the Department of Neurology provider? Was this going to be a co-managed setting in which there was going to be a sharing of the care between primary care provider and neurologist to be determined in some fashion? Or was this going to be a one-off consultation in which, subsequent to a set of recommendations, that patient would then be returned to the care of the primary care provider? In any event, finding out any of those things was only present in less than 7% of the referral requests. In an additional third, by reading other clinic notes within the electronic medical record, the neurology provider could infer what the nature of the referral to neurology might have been. But this is something in which there's obviously lots of room for improvement. So that fundamentally for patients coming into these pilot sites, little documentation existed regarding any of those questions. If we then look at the integration quality for follow-up visits, follow-up visits fundamentally have no structured mechanism that closes the loop by which either the neurologist hears from or can communicate to the primary care provider about new or ongoing expectations or needs. Most of the communication is discovered and demonstrated to be either ad hoc or fundamentally dependent upon the patient, their family, or the caregiver that accompanies them to relay to other members of the patient's care team. This, therefore, obviously allows for lots of things to fall through the cracks and also for needs to go unmet. Next slide, please. So if we look at closing the loop in terms of what actually transpires within the context of the clinic, this looks at 130 visits across 8 clinics within the Department of Neurology. If we begin with the note created at the time of the encounter, and we then say that someplace in the text of that note, usually near the end, the provider states that there was an intention for some lab to be ordered, we find that about half of the encounters involving patients resulted in some lab order. If we then start tracing that downstream, in only 3/4 of the instances was the lab order actually completed. Of those then completed lab orders, in only 3/4 of the instances were the families notified of the test results, and even more concerning, in slightly over 1/3 was the referring physician or provider notified of the test results. If you do the math across that, it means that we have about a 13% hit rate in terms of families finding out what the results of their child's lab tests were. Quite unacceptable from our perspective. If we look at visits that then required a secondary consultation, that happened about 1 in 5 times. In only half of those was the consult order actually executed after its intentionality had been noted within the note itself. although in terms of the neurologist receiving a result back, that seemed to be much more successful. More than 9 out of 10 instances was a consult note returned. But this shows us that there are lots of open-loop communications going on that really lead to difficulties in care, the possibility of missed diagnoses, and other undesirable medical outcomes. Next slide, please. So we then instituted an attempt to try and close these loops. So we took a set of baseline measurements in the context of the Red Clinic from the fall of 2013 to the spring of 2014. And then an intervention was instituted in April 2014. That's a pretty simple intervention. The idea was a meeting that occurred before the clinic to determine what it is we were about to do, and then a meeting afterwards that discussed what it is we'd just done to make certain that there was ownership for every task and what the status of those orders were. That process is shifting to an electronic communication process to better fit this team's workflow. But if we look at this here, some rather significant progress was made from the initiation of this. There was a bit of a backslide in the first, or rather the second quarter of 2015, but overall, this process has been driven up quite significantly in terms of both completion of laboratory orders and communication of those lab orders, at the very least, to families, less so or less successfully sustained in terms of providers. Nonetheless, it appears that a relatively simple care integration intervention leads to significant improvement in practice. If we could have the next slide, please. This looks at what the results of the Pediatric Integrated Care Survey across 100 families of children with complex care needs have shown us. This tool, which is funded by the validation, which is funded by the Lucille Packard Foundation for Children's Health, has given us some of these salient pieces of information. So the first question that we have is, does your child have a place that provides routine preventive care? And for the vast majority of the families with whom we work, the answer is yes. There is, however, a concerning minority of children and families for whom that answer is no. And that has led us to investigate what we can do to make the provision of primary care for those families more robust, since, as we've discussed earlier in this webinar, having a functional medical home is completely essential to the adequate care of a child with complex health care needs. If we look at the second slide on the top, were you treated as a full partner in your child's care? The way I look at this as somebody who runs the behavioral neurology clinics is that there's far too many answers here that, from my perspective and family's perspective, is not acceptable. The answer to this should actually be always, or at the very least almost always, and the fact that we have close to 30% of families saying less than that is, to my mind, examples of room for significant improvement. If we move to the lower left-hand slide, who coordinates visits and treatments to make sure that your child's health care goals are achieved? We can see that in the vast majority of instances, 80% or more, it's the family that's doing this care coordination. Again, this is something that we need to work on and make certain that we have more robust resources so that families don't serve as their own care coordinators, particularly in light of children that have as many health care needs as you saw in the first slide in my section of this. And then finally, how many times were you offered opportunities to connect with other families who might be of help or support to you? Again, I think all of our experience has been that family-to-family connectivity is one of the best ways to support children with special health care needs. And you can see here that more than half of families never had the opportunity. Again, something that we now can take, having captured this, and work with within the context of our various clinic settings, utilizing the services of our resource specialists as well as the other providers. Next slide, please.
Thank you, Dr. Yan. Now it's my pleasure to introduce our final speaker. Tammy Chase is the nurse manager of Boston Children's Primary Care at the Martha Elliott Health Center. Ms. Chase has over 24 years of experience in nursing and practice management in a primary care setting, as well as the startup of a successful urban pediatric practice. Ms. Chase's knowledge of the current trends and issues facing our country's health care system, combined with her commitment to nursing and innovation, has helped her lead the Martha Elliott Center in the creation of a successful care coordination team. Ms. Chase represents another key partner in the team-based approach that is so critical to pediatric care coordination. Ms. Chase.
Thank you, Diane. I am honored to be a presenter at this webinar and very excited to share with all of you how Martha Elliott has used CCMT. I have no relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in this activity. I do not intend to discuss an unapproved investigative use of a commercial product device in my presentation. Next slide, please. Martha Elliott is an urban primary care practice in Jamaica Plain and has been an essential part of its community for more than 40 years. We are a medical home in the heart of the community, serving its families of its neighboring low-income housing development and the greater Boston area. Martha Elliott has a very diverse patient population. 85% of our patients are covered by Medicaid. 85% of our patients are Spanish preferred speakers, and we serve a low socioeconomic family population. Our patients have poor health status, along with a sizable cohort of children, adolescents, and young adults with special health care needs. Additionally, Martha Elliott has become a growing primary care site for the international patients and families seeking care at Boston Children's Hospital. Due to a transition, change in leadership, and a merger with another primary care site, significant growth in our mental health department is expected for 2015 and 2016. Next slide, please. In the midst of many staff changes and vacancies coupled with our vulnerabilities of our patients and families, as well as our growth expectations, I, as a nurse manager, saw a need in our mental health department for a registered nurse role. This nursing role would provide clinical support to the providers, enabling them to maximize visits and improve patient access. They would support care coordination efforts, much of which is currently being done by the providers. They would conduct inter-visit patient care and education, improve medication safety and compliance, improve patient adherence to appointments, and to support interprofessional collaboration with internal and external care teams. To summarize, the goal of the registered nurse would be to provide clinical decision support, education, and inter-visit care coordination, allowing the mental health clinicians to work to the top of their license, improving the safety and quality of patient care, increasing access to care, and providing the best possible patient experience. We were approved for a temporary 20-hour RN position for a 6-month trial period. Next slide, please. Through the successful implementation of the care delivery model, our care coordination team in primary care, I felt strongly that we could demonstrate the improvements to care necessary to validate a need for a permanent registered nurse in the ambulatory mental health department. Validating inter-visit work and putting a value to that work is difficult to demonstrate. As a nurse manager, validating improvements to patient care and outcomes would be the only way I could justify to the hospital the need for this permanent position. I was aware of the care coordination measurement tool but had not put it into practice and really wanted to learn more. I elicited the help of Dr. Antonelli and Hannah Rosenberg. The tool is exactly what we needed to capture for information, but much of it did not apply to the mental health outpatient space. With the interprofessional collaboration of Hannah and Rich, the medical director, and I adapted the CCMT to capture information and tasks relevant to an outpatient mental health department. This has not been currently achieved yet. The tool is integrated into our electronic health record. We captured this data for a 3-month period of time. A wide array of data was gathered from 155 encounters between December 2014 and March 2015. The data demonstrated the added value of having a registered nurse's clinical skill set in the department, supporting the psychiatric physician, nurse practitioner, patients, families, and caregivers. Improvements were seen: patient compliance with scheduled appointments, responsiveness to high priority care, improved rates of medication compliance, and preventable patient outcomes. Some example data points. Of the 155 total captured care coordination activities, 115 encounters involved medication education. 74.2% of those encounters resulted in preventing the patient from abrupt discontinuation of their medication treatment. 126 encounters involved reinforcement of the importance of continuing with medication treatment, assistance with prior authorizations, and refills. 81.3 of these encounters resulted in continuing with medication treatment. 97.4% of the recorded encounters required the clinical competence of the registered nurse. This information was utilized to present to hospital leadership to seek approval for a permanent registered nurse position. Demonstrating the impact of nursing support in the department was validated by the data collected in the CCMT. We have seen an increase in medication compliance, improvement to our show rate, and an increase in patient access. As a result of the support provided by the RN, we have also received very positive feedback by the staff in the department as feeling very supported. I am very happy to report that we have received approval for a permanent 20-hour position and awaiting FY16 budget approval to increase this RN position to 40 hours in September of this year. Our next steps. I will continue to work closely with Dr. Paul Hammernuss, the Director of Mental Health at Martha Elliott, and the team, as well as the entire mental health team, to demonstrate an enhanced best practice model of care delivery in the outpatient mental health department. Thank you for allowing me to share my use and our use at Martha Elliott of the adapted CCMT tool at Martha Elliott. And at this point, I will turn it over to Diane Baker, who will take it from here. Thank you. Next slide.
Yes. Thank you, Ms. Chase, and to all of our speakers today. Thank you so much for your questions, and thank you again to today's speakers. This webinar series was presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal Child Bureau of Health Resources and Services Administration. The National Center houses a number of care coordination resources on their website and on the sites of their partners. These resources include clinical guidance, tools, videos, a comprehensive curriculum, and a measurement tool. Visit the links on your screen for more information, and do not hesitate to reach out for individual technical assistance. This webinar recording, slides, and unanswered questions will be archived for about a week from today on the National Center website. Since it is the third and final webinar in our series, you can also find the materials from the first and second webinars on that same site. Additionally, you will receive an email asking you to complete an evaluation. It only takes a few minutes of your time and is quite valuable to us. If you are in a room with your colleagues, please do access the evaluation and let us know how many participated. Have a wonderful day.